Okay, so you don't have to know PJCs if you read that somewhere, but PVCs and PACs, right? And our last two slides are just summarize everything we've been talking about. What are the causes? What are the treatments? And what are the indicate the nursing interventions I have to do for our patients? All right, so PVCs versus PACs, really quick tack on here. So PVCs, they are going to be wide. So how do you know you have a PVC or a PAC? One of them's wide, one of them's narrow. Which one's wide? That's going to be the PVC. What is wide? We're talking about the QRS. The QRS is wide. It is a PVC. QRS is narrow. That's a PAC. We're not really talking about PJCs right now. That's not what you're responsible for. A PVC is wide and irregular, and it happens where you don't expect it. It happens all of a sudden, right? All of a sudden you got a premature contraction of the ventricles, or it could be a PVC most commonly, or a PAC. The only way you tell the difference between a PVC and a PAC are early beats, and one's wide, one's narrow. So what causes it is ischemia. Your lights can be low, right? When your lights are low, your heart is more prone to get depolarized real quick, such as a PVC or a PAC. So it's the same causes for both, really. Right? And then stimulants. So drinking too much caffeine, more than 400 milligrams in nursing school per day might do it. All right. And again, characteristics are it's irregular. The PVC is wide and bizarre. Okay. And it's always wide. There's not a PVC out there in the world that is narrow. Just PACs can be narrow. Right. And PACs, as we'll come to find out, have a P wave preceding it because they came from the atria. PVCs come from the ventricle. They're premature ventricular contractions. Therefore, they're wide QRS, no P wave before it. Okay, there's no real treatment until you have how many in a row? 3 in a row. 3 plus equals VTAC. All right, so again, dangerous PVCs, 3 in a row equals VTAC. And what's worse, whether you have polymorphic or monomorphic, how heck do I tackle if it's mono or polymorphic? So this is coming from the same site, same source in the ventricle, whether it be the right or the left, whereas a polymorphic comes from multiple sites. So you can see, for instance, let's see a good one. This one came from over here in the bottom left. This one came from a different part of the ventricle. This came from, looks like almost another part of the ventricle. That is much more dangerous than just one source of one little ectopic site. You don't want to have multiple ectopic sites, otherwise you're putting us at risk for not only VTAC, but also VFib. Okay, and also it's not great to have them in a row. If you have 2 in a row, that's called a couplet. 3 in a row, that's called a triplet, and 3 plus really is VTAC, right? And that requires intervention. So here we have multiple PVC that's happening on the T wave, and that's causing us to have polymorphic VTAC, right? So that puts us at risk. Bigeminy is not great because that can lead to just plain old VTAC. The next, you go from quadrigeminy to trigeminy to bigeminy to just unigeminy or VTAC, right? That's an ectopic focus. If this keeps going faster and faster and faster and faster more frequently, that is VTAC, right? So this rhythm right here, you can see every other beat. That's bigeminy. So bigeminy versus couplets, you can kind of see the difference. Couplets is just a pair, whereas bigeminy is a pattern where it's every other. This is every other second beat. So it's 1, 2, trigeminy, 1, 2, trigeminy, 1, 2, trigeminy. And here's 1, 2, 3. And there's a little quadrigeminy, 1, 2, 3, quadrigeminy, right? So that's a way to tell a difference with PVCs. There's different characteristics of PVCs. All right, so PACs. Are PACs wide or narrow? PACs are narrow because they came from a ectopic site inside the atria. The little spot in the atrium is irritable and it fires off, and it gets conducted normally via the His-Purkinje system and normally through the ventricles. The ventricles are not impaired. It's just a premature atrial contraction. All right, so you have a P wave that's going to look different. So if you look at this P wave here, that's the intrinsic P wave, and this P wave is kind of early, right? You can also tell over here, for instance, all right, we got this P wave. This is actually bigeminy. Not a beautiful example. This would be a good, better example here. All right, there's our normal P wave, normal, normal, normal. This beat came early, right? And look at this P wave's upside down, right? So that is a not from the normal SA node, that is from somewhere else, okay, in the atria. And because it came from the atria, it's going to go down the AV node like normal, and it's going to be a narrow complex. All right, so PACs versus PVCs, what's the difference? One has a P wave. Which one's that? That is our PACs. And which one is narrow? That is our PACs. Which one's wide? PVCs. Which one's early? Both of them are early ectopic beats that happen unexpectedly. Okay, so a little practice here. So what is this? Well, they are all narrow. So that clues us in. It's probably a PAC if this is the PAC chapter. But how would I recognize this if it wasn't the PAC chapter? Look at this irregularity here. So this is irregular. This rhythm looks irregular. Why is it irregular? Well, I would probably bet money might be AFib, but I see P waves. So the fact that I'm seeing P waves might think, and it's irregular, it's like, well, maybe shoot, they have a dropped QRS complex and they have a second degree type 1 or type 2 AV block. But look, the PR interval is nice and narrow. It's less than one big box. So it's not that. So what's the other option? I got a little PAC. Look how different this PAC is, this little P wave, than the normal P wave. So it came from somewhere else in the atria, an ectopic site. All right, so this is just a PAC, but is that the completion of our interpretation? No, PAC is a extra spice on our rhythms. We have to identify the underlying rhythm. And what's the underlying rhythm? So let's find a normal. This guy kind of lines up, 300, 150, 175. This is sinus rhythm. Is it normal sinus rhythm? No, because normal sinus rhythm does not have PACs. Okay, so that is sinus rhythm with PACs. Next guy. So I got narrow complex, wide complex. Why do I have a wide complex every other beat? All right, is that expected? No. So the fact that it's wide and it's not expected makes it a PVC. And what's the underlying rhythm? It's hard to tell if it's sinus rhythm or sinus tach, but this is, it's actually pretty regular, and this PVC is occurring regularly. This PVC has a pattern to it, so this is happening every other beat. So that's called bigeminy. All right, so it's probably sinus rhythm with bigeminy. Little T-wave inversion too. Yep, right before the PVC, the little T-wave inversion, and this is getting a little close for comfort. That's going to be right on top of that T-wave. Okay, all right, number 3. So everything's narrow, but it's irregular, and I got P waves, so it's not AFib. So why is it? What's going on when I have P waves and an irregular rhythm? So maybe I could have a drop beat, but that's not the case. This is just early beats here, little PACs that are early, and you can tell how the P wave looks a little bit different between these two. Okay, that's a clues us in that if it's early and narrow, and it has a P wave, which it does, that's a PAC. All right, next one. Ooh, that's wide and irregular. That's already PVC. I can maybe name it as well, give more detail. If that PVC happens every what? 1, 2, 3 beats. 1, 2, 3 beats. So that is trigeminy. Why is it not a triplet? Triplets are 1, 2, 3, and then your regular rhythm, right? This is happening every third beat. And that's, again, spice. So this is sinus rhythm with PVCs. I can be more specific. I could say with trigeminy or trigeminal PVCs. Okay, next one. Well, I have like a bundle branch block underlying it, so that's throwing us for a little bit loop, right? But look at this P wave. There's our normal P wave, normal P wave, normal P wave. But look at this P wave's upside down. So that is looks pretty fast too. So it's a sinus tach with a PAC, right? Does it have a pattern to it? Got one there, one there, one there. Yeah, it's happening every fourth beat. So I got 1, 2, 3, 4. That's supposed to be a 1 and a 2. Then we got 1, 2, 3, 4. 1, 2, 3, 4. That is a quadrigeminy, quadrigeminal PAC, and it's sinus tach with a quadrigeminal PAC. Okay, and also bundle branch block. We forgot about that. And also we said our PAC was quadrigeminal if we're looking at more patterns there. All right, next one. We got a wide QRS complex amidst normal stuff, right? And again, this is happening every fourth beat, looks like. So this is a quadrigeminal PVC, all right, amidst a sinus rhythm. Is that really sinus rhythm? Let's double check our work here. So we got, let's find one that lines up pretty nicely. This guy lines up. Got 300, 150, 100. It looks like it's almost sinus tach. Also, remember this is irregular, so we should be using our 300, or sorry, our 10x method, where we got 1, 2, 3, 4, 5, 6, 7, 8 beats in that 6-second strip. So that's a heart rate of 80. Okay. All right. What else we got here? We got a premature beat there. So you can see that this P wave looks different than this P wave. It's also a narrow complex. There's some ST depression there, but this is sinus Brady with a ST depression with a PAC. What's next? We have a big PVC. Look how different those PVCs are. That's a multifocal or polymorphic PVC, right? And it's definitely PVC. Why do I say PVC and not PAC? Because it's wide, bizarre. It's like, well, shoot, the underlying rhythm is also wide. They might have a bundle branch block. Why is this not the one in like number 5? Well, it's because there's no P wave really preceding this, right? That I anticipate. Okay, so that's a multifocal PVCs. Also, those first degree AV block, we didn't mention that. Just look how big that's bigger than a big box, right? Here definitely has some ST elevation, right? The ST, that's supposed to be a straight line. So you can see the ST elevation is there, all the way across. And then we have an early beat right there, right? It looks the same as the other ones, so it's just early. And so it's probably came from a little ectopic site. So that's a PAC, but it's definitely pretty fast. This looks like a fast rhythm here, right? 300, 150, 100 beats per minute, and it has a PAC thrown in the mix. All right, so sinus tach with a first degree AV block. Shoot, missed it again. So you can see how that's bigger than a big box. There's a first degree AV block, some ST elevation, and PJCs. We're not going to fool you with PJCs. We'll just stick to PACs for now. But technically, yes, I don't really see a P wave on this one, so that would technically be a PJC when you discuss PJCs, which we can talk about more in clinic. All right, so I added these ones in here. So we got a wide complex all of a sudden. So that's definitely PVC. I mean, am I going to say this happened every 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11? What is 11? Octo plus tri? I don't know. Is that going to be? No, there's not really a real pattern to it, but it is just unifocal. It looks the same, came from the same site in the ventricles. There's definitely a fast rhythm, so it's sinus tach. Well, is it sinus tach? Well, I don't really see P waves, so it might be SVT, right? It's a really fast rhythm. It came from the atria because it's narrow, so it's SVT with PVCs. Yeah, paroxysmal SVT with unifocal PVCs. This definitely looks like some flutter activity here. We got 3 flutter waves there. We got 3 there, 3 there. We got 3 there, and then all of a sudden we got a big PVC, right? So we got a flutter with PVCs. A flutter usually is 3 to 1. It's rate controlled because the heart rate is what? 60 to 100. And here we got some PVCs. Oh shoot, because how do I know they're PVCs? They're wide, irregular. There's also what's called a compensatory pause afterwards, which is extra credit, but you got 2 PVCs there and they look different in shape. That's not good. That's really set us up for VTAC. If I just had 3 beats there, that'd be VTAC, right? I got a P wave and a QRS complex. My heart rate is pretty fast. My underlying rhythm is 300, 150, about 140. And I got some 2 PVCs in a row. That's not good. Sinus tach with multifocal PVCs. Bigeminal. That's actually an error. That is a couplet. All right, and then next, everything's narrow but irregular, and I got some P waves, so that's leaning me more towards some PACs on my rhythm here. And then I got a little P wave right there, which looks different than this P wave here. So I got a P wave, I got a PAC almost every other beat, right? Almost. So not a true pattern there, but I have, this is irregular, so I got 1, 2, 3, 4, 5, 6, 7, 8, 9. I got a rate of 90. I got sinus rhythm, right, with PACs. Okay, up top, I got this wide rhythm right here. We'll learn about next semester. That's an idioventricular rhythm. But the key thing is I got a PVC mixed in this idioventricular rhythm. That's PVC attached to it. Okay, so you'll talk about that next semester. But this one we know about. We got a P wave, we got a QRS followed by a QRS, and we got a PVC here, PVC there, PVC there. How do we know it's not a PAC? Because it's wide, right? And I know my normal rhythm is narrow, so it's a wide complex thrown in the mix here. So also what's concerning here is it looks different every time. That's called a multifocal PVCs. Do they happen every beat? Just about, yeah. Multifocal PVCs. Here we got almost, it looks like a borderline bundle branch block, but we definitely have an abnormal situation here. So that's a pretty fast rhythm, sinus tach with PVC. All right, and what's next? This looks pretty dang slow. We got 300, 150, 100, 75, 60, 50. We're going really, really low there. And we got a PVC to precede it. Sinus braided with a PVC. And right down here, we got, that looks pretty early. Got a space in here for some reason. So that's abnormal. This P wave is like all over the place. That looks normal, but then we have this early PAC. It's narrow, it has a P wave, it occurs earlier than expected, premature if you will, and that's considered a PAC, sinus rhythm with a PAC. All right, some more practice. So we got pointing to a P wave that is upside down. So it's coming from somewhere in the atria, probably close to the AV junction, and it's early. This looks like a slow rhythm, right? So this is a sinus brady, or we got a first degree AV block there too. Look at that. It's longer than a big box. This might be computer generated. I'm not sure if this is an accurate patient or not, but sinus brady with a first degree AV block, plus we got a little PAC thrown in there. Let's see what we got here. Yep. And then next, we got our normal intrinsic rhythm is a narrow complex, and they got this huge pause here. So that looks like some AFib in there, because those aren't really, P waves to write home about. And I got a little couplet right there, and I got a big PVC right there. They look different. That's not great. So I got AFib with a what rate? 1, 2, 3, 4, 5, 6, 7. AFib, rates controlled with some PVCs. A PVC and a little couplet as well. This guy, everything's narrow, and I got a P wave, QRS, P wave, QRS, and this looks a little bit different than this guy over here, right? So I got a PAC proceed unexpectedly. I got a premature beat. It's early. This little beat right here is earlier than expected. Otherwise, everything's regular. I just got that early PAC. So it's a sinus rhythm, looks like, with a PAC. All right, and then this guy. There's my normal intrinsic rhythm right here. And then I have a wide, bizarre, early complex that looks different every time, which is not good. Looks like multifocal, bigeminal PVCs attached to my sinus rhythm there. Okay, and then I got so it's like plus multifocal. All right, and then this guy 23, we got a wide, early complex, no P wave, but also it's super wide, and our normal rhythm's narrow, so that tells me this is unexpected. So this is a sinus rhythm. We got 300, 150, 100, just borderline. Might be sinus tach, sinus rhythm, somewhere in there with a PVC. Okay, and over here we got a is that a drop beat? Let's see what's going on. We got P wave, QRS, P wave, QRS, P wave, QRS, and this actually might be a block thrown in here. This might be an error, because that's unexpected. That P wave actually didn't get conducted. It's an early PAC, but didn't get conducted because they might have an AV block of some sort. So that's a little bit tricky. I would not do that to you. Okay, that PAC is missing in action, MIA. Okay, that's supposed to say MIA. All right, and the next one, we got a PVC. PVC looks the same, but it's every other beat, right? So that's bigeminal PVC. And the underlying rhythm looks pretty slow. 1, 2, 3, 4, 5, 6. If I multiply by 10, it's a heart rate of 60. But it looks pretty slow. It might be a sinus brady with bigeminal PVCs. Let's see what we got here. Yep. All right, this guy. PVCs look good. It's happening every 1, 2, 3 beats. So that has a pattern to it. So it's what's called bigeminy, trigeminy, quadrigeminy. That is trigeminy. How do I know that's not a PAC? Well, there's no P wave, but also it's wide. It's wider than the underlying rhythm. Okay, so it's sinus, not too fast. What? 300, 150, 100. So it's between 60 and 100. Sinus rhythm with PVCs. What kind of PVCs? Trigeminal PVCs. And this one right here, we kind of just demonstrated this in the slides, but we got a PVC that happened right on the T wave. We had PVC before, we had a PVC right there. That one almost did it. And we got this PVC is right on the T wave, it's R on T, and now we've gone from multifocal bigeminal PVCs into torsades de points. They got a torsades pattern to a VTAC that gets bigger and smaller, bigger and smaller. So that's what we got there. We had sinus braided with bigeminal multifocal PVCs, which led to a RNT and torsades. All right, so EKG summary. So intervals and important intervals are the PR interval, because that's going to tell you if you have an AV block or not, right? First thing is PR interval is prolonged, and then I have a drop QRS. That's a second degree AV block, but this PR interval is really going to be the first thing that prompts us to figure out if they have an AV block or not. QRS prolonged, that's just bundle branch block. It also might be a PVC, right? Especially if it's unexpected early. And then P wave morphology, T wave morphology, we're not really focused on. T wave inversion, ST segment stuff, that's more MedSurg 3. But QT, that is important to discuss, right? We have the QT all the way down here. QT is important to figure out if they are a risk for torsades or not, which they are if their QTC is prolonged. Greater than what? Greater than 0.45. Okay, and PR interval greater than 0.2, right? So summary, what are the causes and what are the symptoms? What are the diagnostic tests I can do? What are the complications, the treatment that I'm going to do for my patient? What are the complications? And then finally, what are the nurse interventions? This just summarizes everything we've been talking about. All right. Causes is just, if it's not sinus tachycardia or sinus bradycardia, it's probably you have scar tissue or ischemia that's happening. You have myocardial ischemia, of a heart attack in progress, or you have anatomical stretching and valve issues, or something going on that's making the heart not conduct correctly because it's been not a normal heart, but it's been stretched out atrial-wise, or the right ventricle has been stretched out. So there's problems there that might be causing like a VTAC, or this one might be causing an atrial attack of some sort. It might put you at risk for PSVT or a flutter or AFib if it's very unorganized, right? And then irritants and electrolytes. The lower our electrolytes are, the more prone we are to ectopic activity like PVCs, PACs, VTAC, tachyarrhythmias, and like, right? SNS causes an important thing that causes every tachyarrhythmia. The only reason why someone has VTAC versus sinus tac is a person with VTAC has a sick heart that's anatomically scarred or has electrolyte issues, right? Otherwise, you're still going to have a tachycardia because you still have hypoxia, you still have acidosis, you still have fever, you still have stress and anxiety, right? It's just which heart is more sick. Is it a 75-year-old heart with multiple open heart surgeries, or is it a 35-year-old heart, right? And then H's and T's, this is for all lethal rhythms. We want to examine and make sure if someone's heart has stopped or they're really, really sick and keep having these lethal rhythms, what are we missing? So this is H's and T's are designed to figure out why is our heart not working? Why is our heart rhythm not working? So this is a nice T right here and kind of almost an H. That's also a T. But anyways, I thought there was an H there somewhere. That's my fault. So let's find out where the H went. There's a picture somewhere about an H. Either way, we got low volume circulating around. Our blood pressure is low. That's going to make us have VTAC if we have a sick heart, or that might have a sinus tac if we have an okay heart, right? Hypoxia we talked about. Hypoclemia puts us at risk for episodes of ectopy and VTAC and such, and VFib. Hyperkalemia makes us really bradycardic and PEA. Hydrogen ion excess does the same thing. And actually, hydrogen ion excess actually can cause a rise in potassium. Hypothermia causes really severe bradycardia to the point where our heart doesn't beat at all right? Because those enzymes can't function. And pneumothoraces and tamponades is more like kind of leaning towards trauma, but MIs we've talked about, and PEs, PEs especially, risk factor for which arrhythmia is AFib. If AFib doesn't cause a stroke, it can put you at risk for a pulmonary embolus, a clot that travels to the lungs. And then toxins. You can overdose on medications and drugs that can make your heart go into a lethal rhythm. What's every patient can complain of if the heart rate's fast? Palpitations is for every tachyarrhythmia, right? Bradyarrhythmias, they're not going to have palpitations. They're just going to start they're going to have low cardiac output, just like you can get with fast rhythms. So you have chest pain, shortness of breath, hypotension, confusion with any arrhythmia. Bradyarrhythmias or tachyarrhythmias, right? That's just a sign of poor cardiac output. And what's the worst one of these? That's hypotension, because that's going to tell us whether we can give our medications or not, right? Diagnostic tests you do for EKGs in general, 12 lead is our bread and butter. That's going to take a closer look to see what else is going on. Labs are looking for electrolytes, especially magnesium. If the magnesium's low, all the other ones are low too. And also low mag is a risk for what lethal rhythm? For torsades. An echocardiogram, as we'll find out in cardiac, that's going to, that's really the bread and butter of cardiac. So you can't figure out what kind of cardiac disease they have, do an echocardiogram. An echocardiogram will, if they figure out why they have all this AFib, you realize, oh shoot, look at how big their atria is, right? Or they have this valve issue, or they have something going on there. And EPS study is a specialized thing. They can go and take a look at their hearts in the cath lab, and they can look to see exactly where an ectopic site is, exactly where the AFib or A-flutter is coming from, exactly where the PVCs are. And if they can figure it out, they can go ahead and cook it at 95 degrees and stop that ectopic site from causing problems. All right, so treatments. It's the underlying cause. That's always the right answer. H's and T's are important for our lethal rhythms, and for sinus tachycardias, you're treating the hypoxia, treating the fever, treating the low blood pressure, treating the low blood sugar, right? Treating the dehydration and low blood pressure, right? That's for all tachyarrhythmias. For bradyarrhythmias, we mentioned dye was our mnemonic for bradyarrhythmias. Are there drugs, ischemia, or electrolytes that are causing problems? And we might need to treat those underlying problems, but in the meantime, we're going to hit them up with some atropine, some dopamine, epinephrine. We might even need to pace them. All right, and then tachyarrhythmias. So again, what kind of medication you give? You give your ABCD drugs. You can give, if they have ventricular rhythms, amiodarone plays double duty, right? Amiodarone is the only one that does both. Beta blockers, calcineurin blockers that are non-DHP, and digoxin, those only work on the atria. And yes, there is an exception to one of the beta blockers, but we're not going to get into that. All right. But when blood pressure is less than 90, it's time to shock them with cardioversion. And usually when blood pressure is less than 90, the reason why you have a blood pressure is because you have a pulse. So we're doing synchronized cardioversion. You would not have a blood pressure if you had no pulse. That's a lethal rhythm, and you only shock certain lethal rhythms. Okay, but if you have a really, really fast heart rate and they still have a pulse, you're doing synchronized cardioversion. No pulse, it's CPR and epi plus or minus a unsynchronized cardioversion or defibrillation. So you defib rhythms that have no pulse when it's not asystole or PEA. Everything else you shock, basically. And what is everything else? Well, there's only 5, right? You have VFib, VTAC, and VTAC has torsades also. So that's 3. And then we have our PEA asystole. We don't shock PEA asystole. We just do CPR and epi for all 5 of those, looking for the H's and T's at all times. And then we are going to either shock or not shock. What's shockable? VFib, VTAC, and a flavor of VTAC called torsades or polymorphic VTAC. Okay, what are the nurse interventions for every EKG ever? Is ABCs unless it is CABs, which is your compressions, airway, breathing. So when you do compressions, first over airway and breathing, when there's no pulse. No pulse is compressions at first. Otherwise, you got time, you're going to get some oxygen, you're going to do some vital signs, especially the blood pressure, because the blood pressure will tell you if you're symptomatic or not and what medications you can or can't give, All right, and systematic approach, you can have a system to it, but basically as long as you hit all the boxes, that's what's important. Looking to see if it's regular or irregular really guides you down the right path. What the rate is will then tell you even more, because if I have an irregular rhythm, it's probably AFib 8 times out of 10. But then I look to see, well, shoot, what's my rate? Do they have AFib RVR, or do they have AFib that's controlled? And then I look to see, do I have all my complexes? If I have an irregular rhythm and a P wave, it's like, well, shoot, what do I have a block on my hands, or what's going on? All right. Intervals are very important, because how do I know I have an AV block? I have a PR interval that's prolonged, right? If my QT interval is prolonged, I need to be on the lookout and look to see if their patient's at risk for torsades, like what's causing the QT to be so prolonged, right? So PR interval greater than 0.20, that is an AV heart block. And all of our AV heart blocks are flavor to the underlying rhythm. The only exception is our third degree AV block. That's its own thing. Okay, so ischemia. So ischemia is a important thing to see when MedSurg 3 comes around, because that's always on our worrisome list, because that requires everybody kick into gear. That's a medical emergency if someone has ischemia on their EKG. Okay, and that you can tell that because of the ST or T wave changes. And then ectopy. That is just more flavor to add on to our sinus rhythms or to our AFibs and such. And that's going to be a PVC or PAC. There's such thing as a PJC, but we're just going to focus on PVCs and PACs.
Gosh, why isn't my heart rate coming down? You already have me blown through straws like an idiot. Then you almost drowned me in a bowl of ice water. Now none of the medications are working. How are you guys going to get my heart rate down?
You gonna tell them? Tell me what? We're gonna have to electrocute you.
You're going to do what?
Honestly, it's the only thing left to do, and I'm pretty sure we got it down by now.
What do you mean, pretty sure?
Well, I mean, we shocked that guy in the P wave, and then that guy, we shocked him on the T wave, and then this dude back here, we just close our eyes, push the button, and hope for the best. It wasn't the best for him. But we're gonna shock you on the R wave. Guys, I mean, R's gotta be right? Gotta be. Guys, wait, doesn't wrong start with R2? What? I don't know. Anyways, clear. Maybe next time. I think I peed myself. Yeah, it happens.
All right, that's it. Thank you.